Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
And since we're talking about scenarios, our very first scenario that we have set up is flash pulmonary edema.
Ooh.
Perfect.
All right, so you get to your scene, and what you see is severe shortness of breath. Your patient cannot speak in full sentences. They have pink, frothy sputum. What would you expect their lung sounds to be?
I would expect probably global rails.
Yes, rails, crackles, whatever y'all call them. All over the place. They are hypertensive with a blood pressure of 200/110, and their SpO2 is in the 80s. So let's go through our steps. What are we thinking? Is this an oxygen problem or a ventilation problem?
Well, there is definitely fluid in the way of them being able to get oxygen to their alveoli.
Absolutely.
Yes.
So we have something in the way, and oxygen can't get to their alveoli because there's fluid in the way. So it is an oxygen problem. Now, what about their ventilation? Where are we at there?
They're breathing real hard.
They cannot speak in full sentences, so they're trying. They're
trying.
giving it a valiant effort. I'll
They're
say
still
that.
moving the air, right? Yeah.
Which, for terms of our ventilatory status, that means that we are trying, we're breathing fast, we're breathing hard, our air is moving around. So our airway, what are they doing with it?
They are probably stressed. I'd be stressed if I was drowning in my own fluids.
Right, I'd be a tiddly bit panicked,
Yeah, that's reasonable.
right? Okay, so and our blood pressure.
It is very high.
Yep, we are
They can
hypertensive.
definitely tolerate some CPAP.
Yeah, so we're not concerned there. And so what is our decision so?
CPAP.
Right? And maybe we have something in the way. It is an oxygenation problem, and their ventilatory status is decent.
For sure.
So we're going CPAP.
Yeah, and when we set up CPAP, how are we gonna set this bad boy up?
All right, so remember, CPAP is one pressure, right? So you're choosing one pressure. It's both your inspiratory and expiratory pressure, and you're going to start between 5 and 8. A lot of times 5 is a great place to start, and then as your patient tolerates the CPAP, if they're doing well at 5, but their SpO2 is not improving, you can go up,
Yeah,
and you can continue that titration.
Yeah, don't start at 5 because we just think they need 5, but like don't shock them, right? They're already having a scary respiratory moment. We don't need to make that scarier
Yes.
by just
And a lot of times what CPAP feels like is you're just covering their face,
right.
which makes people panic. So if you can go with a lower pressure, then go with a lower pressure. And as you increase that pressure, they'll work with it a lot better. And then what else do we need to do?
From here, this is where you follow your protocols, but this is where you need like a nitrate, maybe some Lasix on board, because we're pushing this fluid out of the way, but now we need it to go somewhere else.
I
We need to send it on its way.
If you have a 30-minute drive to the hospital, or even less, they will be peeing, and I don't even want to hear it from you. Okay? It doesn't work fast enough. It works faster than you've been told it works.
100%.
Correct. We have an average transport of
15.
10, 15 minutes, and I have never one time given Lasix and not have somebody before we get to the hospital tell me they have to pee. Not one time.
Absolutely. And same thing with like nitro, especially that vasodilation. Like we will have patients all the time that improve in that 15.
And that's our gold standard, guys.
Yeah, 15 or so minute drive. Now, what do you do? So clearly I'm putting a CPAP on someone's face, right? Like I'm covering their mouth hole. Well, I only have sublingual nitro. So like what do I do now?
Pop it in there first.
Absolutely.
Yeah.
Put that nitro on them, and then if you need to administer another one, if you're Q3, Q5, then break that mask and put another one on them.
And then obviously if you are blessed with having IV nitro, it works so well, guys.
Bougie.
It's like crazy.
Bougie, bougie,
It's
bougie.
crazy.
Bougie.
Right, and some people have Some people have the spray. Some people
Yeah.
have like a paste. There's
Paste
plenty.
would be ideal for this situation.
It would be. But if you only have your sublingual nitro, don't not give it because you're putting a mask on them. Still give it. It's very important.
Absolutely. All right, that is our pulmonary edema.
All right.
What happens if we have like a COPD that's hypercapnic? You show up, they're just classic tripoding, wheezing, those long exhales. Their end tidal's pretty high. Their SpO2 sometimes is okay. And that's what I want y'all to remember during this little scenario, is that a lot of the times it's okay for them. And then they're telling you that they're just getting tired. I can't do this anymore. I mean, I've heard that a million times. They live in a state of like exhaustion, and they're always having difficulty breathing. So there's a good chance if they're calling you, you're gonna have to pull out all the stops.
Yeah.
Yep. We've had the same. Obs and I have had the same patient twice in the last week and a half. The first transport, the second transport went exactly like the first transport, but he ended up in the ICU for 5 days, on BiPAP. They avoided intubating him because their fear was that he wouldn't come off the vent. Because again, you're not fixing the problem. But on our presentation, he was tripoding, extremely diaphoretic, pursed lip breathing because he's working so hard.
Oh, I remember y'all telling me about this. I can't believe he came home.
Oh yeah.
Well, we've already picked him
And
up
we already
again.
picked him up again.
But I just mean that he is still living.
Yes.
Oh, yeah.
Like wheezing, but minimal wheezing. And initially you hear that and you're like, oh, good. No. We're
Big
not
bad.
moving enough air to wheeze loudly.
Yeah.
End tidal was around 60 to 70. And
That is
SpO2.
so crazy, guys.
Oh,
That is so bad. I bet he already had those like jerks.
Yes. And
Like-
SpO2 was like 92, 93. It was actually not bad.
That is so common, so don't let that fool you. And that is a big reason we need end tidal.
For sure.
Yeah.
And his work of breathing was insane. When I say you could see every single accessory muscle that this man had, you absolutely could. Down to like had a 16 pack. Like,
Yeah, it's scary, guys.
I mean, every intercostal muscle. We had substernal retractions. Like, those videos, those pediatric respiratory distress videos you watch?
True seesaw.
This was this human.
This demographic, like COPDers, that they are chronically short of breath and all, they wait so long to call that by the time that they do, they are tired. Like, they're not
They need
lying when
help.
they say that they can't do this much longer. So,
Yeah.
hint, hint, they are going to need some sort of support
Yes, they're
to
exhausted.
help
And
take the load off.
a lot of these patients wait so long to call because they know what's going to happen.
Yeah.
They know they're going to be in the hospital for days and days and days. They know that there's a potential they get intubated. Like, a lot of them, they think that if they just wait it out, it'll go away. And it's just because they don't want to spend weeks in the ER or in the ICU. So with this patient, what are we thinking? Is this an oxygenation problem?
Not at the moment. They're getting oxygen, right?
Yeah.
Right? So is it a ventilation problem?
I think if we had to go off of one vital sign, that end tidal, that high end tidal tells you everything you need to know. This is a
Absolutely.
ventilation
They're
problem.
getting tired.
Yeah, we're getting tired. So our airway is patent. We're awake. We're talking.
And
Now
that's
poorly,
why
but we're talking.
I like to say, just because, don't ever say, well, they're talking, they're breathing. Okay, they are barely breathing. Don't say that to people.
People,
That's bad.
people
That's
will
bad juju also.
yes, and people will use the last ounce of their energy to ask for help.
Yes.
So like, just
absolutely.
because they say words doesn't mean everything's okay.
Especially the patient that knows what's wrong with them, they've been living with this condition, they are going to tell you, even if it takes their last breath.
Yep. And blood pressure is usually okay. He was hypertensive. All right. So what tool are we using? BiPAP. All right. Unfortunately for us, which this happens often, this patient could not tolerate a mask. Was super, super anxious and would just rip the mask off of his face. Our issue is that we don't carry a great anxiolytic. We only carry Versed. And his drive was already getting to be where it was poor. And the risk versus reward for him was not great. He was able to maintain a decent ventilatory effort without BiPAP. And I was nervous that giving him even a little bit of an anxiolytic would decrease that.
Yeah. And this patient lives close enough.
Absolutely.
Let's get him there.
And yeah, had we had like a 45-minute transport, absolutely, that would have been the move. And we would have kind of honestly faced those battles when we got to them.
Yeah.
But our transport was short enough that there were better agents for him in the ER than the ones that we carried, and he was able to maintain his status. But what we did do is give lots of meds. But in the scenario that we could have tolerated a BiPAP, where would we have started it? Like, what do we start with?
Well, it depends on what tool that you have to titrate this, right? Do you have a vent, or do you just have what you guys have on the ground, where it is just... I'm not sure. What can you all titrate if you have this almost like reversible CPAP, BiPAP?
Absolutely. So you can titrate both your IPAP and your EPAP. What happens is you start it in a CPAP mode, and you start with a pressure of 10. You make sure that that pressure of 10 maintains on both inhalation and exhalation. You then will switch it to your BiPAP mode. Once you move to your BiPAP mode, then you want to make sure that your inhalation pressure maintains and your exhalation pressure maintains. Most of the time that means you increase your flow. This will give you an IPAP of 10 and an EPAP of 5, and then you can titrate accordingly. So with this particular device, you titrate your inspiratory pressure with oxygen flow. So if your inspiratory pressure is too low, you turn up your tank.
And there's a dial where you can see all of that?
Yes. There is a manometer so that you can see all your pressures. And then if your expiratory pressure is too low, there's actually a spinny wheel on the device that you adjust your expiratory pressure with, because it's like your resistance.
Wait, that sounds way more chill than a ventilator.
Yes. So your knobby turn is going to be your expiratory pressure, and then your flow is your inspiratory pressure. And it actually works quite well. The only real trick to it, which is really any oxygenating device, but the biggest trick to it is you have to have a really good seal. You have to have a good mask seal. If you don't, none of your pressure readings will be accurate.
And that's would be probably your difference in BiPAP versus BiPAP on your device that is awesome versus one on a ventilator. You're definitely going to get your alarms if you have a bad, poor seal, that you have low pressure and things like that. So how do you know if you have low pressure when you don't have a ventilator? What would you look for?
So what's kind of cool about this device is that there is a chart that comes with it that they give it to you with, that has like roundabout pressures that you should see with certain flow rates. So you're not just like willy-nilly.
I like that. And guys, you don't have to have everything memorized all the time.
Yeah, there's a chart. It's fantastic. And for both the CPAP mode and the BiPAP mode. But so say you have a flow rate of 8, that should give you an IPAP pressure of 5, right? And as you turn your flow rate up, your IPAP pressure should go up. Now, in practice, because a lot of times people that you're using this on, it's not super easy to get great seals with them.
They always got a beard, I swear.
Yeah, they got a beard, or they got the squishy mouth, or whatever.
No teeth.
Right. Really, I just need a rotund face that just really a mask seats well on.
Yeah.
That never happens. It's like a bony granny. But I have found that you do have to use higher flow rates to get the same pressures, but that's because our seal's not super great. Yeah. But there is a way to kind of overcome that. But it'll give you a good idea. And I mean, you can just hear that hissing out the side of the mask.
And sometimes there is not, even if we have a ventilator, we aren't able to mitigate the leak in the seal because of bone structure, loss of teeth, or facial hair in the pre-hospital setting, and we don't have, the most squishy masks.
Right.
So sometimes you do just have to dial up the pressure.
If you do have a male patient with a beard, or honestly even a female patient with a beard, if you got anybody with a beard, Vaseline gauze. Rub Vaseline gauze on their fefe.
Honestly, you could probably use Vaseline gauze even if it's difficult to get a seal. You know how patients who you can tell that they were obese at one time and they've lost a lot of that weight?
Yeah, have some extra skin.
Yeah, that might be a good place to use that as well.
Yes, it'll give you a better seal.
All right. Now that we got that out of the way, what about pneumonia? They have been working with pneumonia for a week.
Oh,
and now we find them. They have the fever, they have the cough, they have the crackles. They got all the things. They have low O2. They're working pretty hard, but now that you got them to the truck without intervening, they are starting to grow tired. And they're even a little confused. So let's do our step-by-step. Number 1, are they oxygenating?
Not well.
Pneumonia, this is a roadblock, right? Pneumonia is our roadblock here. It's in the way. What about ventilation?
Not well.
They're getting tired.
Yep.
Right? We're starting to fail a little bit.
Yeah. And what about their airway?
Their mental status is no bueno.
Again, not well.
Not doing well.
Yeah.
So this is kind of where we talked about. This is like mixed, right?
Yeah, it's a mixed etiology for sure.
Yeah. So, what's our decision here? Do we want to use BiPAP or CPAP?
I would, for this patient, if your system has it, I would go BiPAP.
Yeah.
Mm-hmm.
What are we worried about here, though? Like, how long is this person gonna do okay on BiPAP?
Yeah, I think this is a patient that if you are going to do this intervention, you had better be preparing to pull this intervention and start with another very quickly, because
Yeah.
it sounds like they are teetering on maybe not having the mental status
Yeah.
to be able to qualify for CPAP
For
or
sure.
BiPAP.
And CPAP and BiPAP is hard because it takes a minute, right?
Yeah.
Your patient has to get
Mhm.
used to it. You got to like really coach them. And sometimes it's hard to figure out when to decide that that patient has failed that therapy.
Yeah.
There's a moment where you're like, but maybe if I just give it one more minute, they'll learn to work with it. This is a patient where you have to make that decision pretty quickly after its application to decide that we have now failed BiPAP therapy, which means that we're going to intubate them.
Yeah, and if truly, I would say that it's more reasonable to put patients on, because I've had patients who I've put on, this was a scenario, I put this patient on BiPAP just because their home health nurse called and said they got ABGs and they were like, their CO2 was through the roof. Okay, he was altered, he was doing that like jerk that they get when their end tidal's really high, and it turned him around so fast. So like, if you can get them to comply, that's great, but he was really altered. So sometimes
That's another,
we do have to do it when they're altered.
And that's another hurdle with alteration, is not necessarily that we think it's unsafe, but that they may not comply.
Right.
Because they might not know what in the world's going
And then
on.
if they start panicking or freaking out with every bit of energy they had left,
Yeah.
then we're game over very soon.
For
Yeah.
sure. And so you need to always have a backup plan and a backup airway for those patients.
And you brought this up earlier, James. Hypoventilation
Yeah.
in our obesity
Yeah.
population. Let's talk about that. I think that was a good one to talk about just because it's kind of outside the box
Yeah.
in how we use BiPAP.
And we live in the South, and so normal weight ranges down here are a bit on the higher end.
Yeah.
But what we're not talking about, like your sweet Aunt Bethesda that has I'm trying to say a name that nobody has an aunt named.
Well, I think you did it.
Anyway, so I'm not talking about your sweet Aunt Bethesda that is over off in BFE, who is carrying like an extra 50 pounds. Like, that is not what we're talking about. We're
Morbid.
talking about like profoundly obese patients that have 300, 400, 500 pounds that just sits on their chest.
Dr. Nels Arden.
For sure. We're talking about Dr. Now. And with these patients, that is a huge amount of weight on their thoracic cavity. And so we talk about thoracic cavity pressures. That is a pressure.
Especially if you are sitting on a stretcher with your legs out in front of you.
Mm-hmm.
I've had this happen to me. I'm sure you guys have too, because we operated in the same zone. Having patients where they're like, I have to get my legs off the stretcher. I have to get my... Just let them.
Mm-hmm.
Yeah.
Just let them.
Yep, because a lot of times, depending on that positioning, that is putting a lot of pressure on their
Yeah,
diaphragm.
if you ever have a tummy ache, if you ever have a belly ache, next time you have a belly ache, just go sit on the floor with your legs, like sitting straight up with your legs out in front of you.
Yeah, it's terrible.
It hurts.
Yeah.
It's not good.
Okay, it puts a lot of pressure on your belly.
It does. And so what this can cause is it can cause, like, one, snoring. You can have obstructive pathways there. But also a lot of times these patients are chronic CO2 retainers, because not only can you not take a deep breath, but a lot of times you can't exhale completely either. Yeah, so they're going to have a higher end tidal, and their SpO2 is going to be like iffy, like probably on that like lower COPD range.
Yeah.
So again, is our oxygenation the issue?
Meh,
Not normally. Is our ventilation the issue?
probably.
Probably. We're probably taking shallower breaths. Our end tidal's going to be higher. Airway, not big problem. They're arousable. Yeah, so these patients are good candidates for what?
BiPAP.
BiPAP,
Just need
right?
A little support.
Yeah, we just need a little extra boost.
And your settings don't have to be even like very crazy.
It could be like a pretty chill. It could be a mild pressure support.
Some patients don't just have weak lungs; they have weak drive, which
Mm-hmm.
when you have to move blood round and round a body that is sometimes double, triple the size that it should be. That's taking a lot more energy and effort just to do. Plus, I mean, put a weighted, blanket on and try to breathe while you already don't feel good. You have some other mechanism going on. Like, it's going to make things a lot more difficult. These are really complicated patients.
Yeah,
so don't
absolutely.
be afraid.
And positioning here is really important. To be able to position your patient, whether that's ear to sternal notch or whether that is just like in a semi-Fowler's position, whatever that's going to look like.
Yeah.
I'm going to tell you right now, it's not supine.
A lot of them are on their side.
Yeah, a lot of patients. We used to have a patient that we would pick up not pretty regularly, but decently. And they were, I think, upwards of 700 pounds and was always positioned on their side.
Thank
Always.
goodness they could position themselves.
Yes, always positioned on their side. And anytime we would have to move them to the stretcher, it was like a calculated movement. And this patient, thankfully for us, was like the salt of the earth, sweetest
Literally
human being
nicest
ever.
person.
Sweetest human ever. But it was very coordinated, and we could only put them on their back to move them for like a total of 10 seconds.
And that even caused significant issues.
Significant respiratory distress. And we would have to do it, make sure that we had everything planned and coordinated to where that was the maximum time that we were on our back. And thankfully for us and for them, it always worked out well. But it was a huge undertaking to figure out how to position this patient
on
where
our
they could
skinny little
breathe.
stretcher.
Yeah.
Yeah. If they need to swing their legs off, I've seen them straddle the stretcher a lot, like sitting in one leg on each side.
Yep.
I'm not gonna get into people's feelings about people weighing that much because it's just not necessary. But I do want to give you some perspective. Okay, if you just had lots of wet towels on you all the time, and then someone laid you down, even though you may be frustrated that you're moving a very large patient, that is unimaginably scary.
It's terrifying.
And they may get a little hateful for that moment.
Yep.
And it doesn't mean that they're a bad person. That is freaking scary. So
It
just
is.
give them some grace, okay?
Yes. And rarely is it truly a behavioral issue. It is almost always fear.
Yeah, it's...
Yeah.
Yeah,
And you will get a much farther way with your patients that fit this population if you were like, look, I know this is scary.
This is why we have to do this.
Yes, and we are going to do this for the most minimal amount of time as we possibly can.
Absolutely.
And I think that just having that conversation with these patients before you like start fighting them and laying them down.
Yeah, and don't get mad at them.
Yeah, and do not lay these patients flat. Don't do it.
If you can help it, yeah.
Obs and I talk about the ER all the time. Not any specific ER, just like the ER in general. About how it is so much based around like provider convenience than it is around patient comfort.
Yeah.
And like we find ourselves all the time in the ambulance working around patients' position of comfort.
Oh, absolutely.
And I mean, in the ER, they will like borderline fight
you have
them
to lay flat.
to lay them flat.
Yes.
And patients will be like, I cannot lay
also,
flat.
I can
can't
get
breathe.
a 12 lead on you if you're on your side.
Yeah,
Don't even come for me right now.
Yeah, we got it.
I can.
I may even be like, hey, can you lay on your right side instead of your left side?
I think it's the structure of our EMS system being pre-hospital is like we typically every single day have to think way outside the box.
Yeah.
So
Yes.
it's just a standard for
Yeah.
us.
But I have watched ER providers like fight somebody to lay them flat. And I'm like, they can't breathe.
Yeah.
That's why they won't lay down. Do it sitting in a chair. You can do everything you're doing in a
can.
chair.
Correct.
Absolutely. They don't have to be on the bed.
Simmer down. But I think
Don't be
that
afraid
is
to put people in
it's
the
a good
captain's chair.
lesson. It's a good lesson to learn.
Yeah.
So some quick rules for your CPAP. You want to start low. Start with lower pressures, so between 5 and 8. It's measured in centimeters of water. And then you want to reassess. So is it easier for you to breathe? Is your patient reporting like an easier time? Is their SpO2 increasing? Is their blood pressure holding, or is it starting to drop? If they're still struggling, but they're tolerating it, then you can increase your pressures like 2 at a time. And that will help. But don't forget their blood pressure and comfort.
Yeah.
And sometimes anxiolytics are a great option for these patients to help them work with the device.
And don't be afraid if they do start declining. Don't think of it as like, oh, they're just not getting better yet. It has to catch up. If they are truly declining after you've placed the CPAP, it's okay to take it off. It is okay to undo something that you did.
Absolutely.
It's not necessarily your fault.
Yeah, if your patient's O2 drops like from 90 to 88 and then improves again, that's an adjustment period. If it goes from 90 to 80
and they get tired,
that is failure.
If they start to get tired once you put them on CPAP, they have reached the point where they need something more than CPAP.
For sure.
Jame has a good phrase that she uses, especially in situations like these. And normally she says it out loud, which I think is adorable. But she, in these situations, like if we are attempting a therapy, it does not go according to plan, we then have to move into the next step. She takes a moment to say, this patient has failed this therapy. And I think that helps bridge the gap in your brain to not be like,
You didn't fail.
yeah,
The
you didn't
therapy
fail.
failed.
We have attempted this. The patient can no longer tolerate this. Time to move to step C. And I think that's a great framework for you.
I agree.
I had to learn that.
Hard way.
Honestly, I think it was in critical care school where they were like, and this is now considered a failed therapy. We're moving forward. And when they said it, it just like something clicked in my brain where I was like, oh, there is like a line. I just have to decide it.
Yeah. Blame the customer.
Right? I was like, I just have to decide that that's the line.
Yeah.
Because beforehand I was like, oh, I don't know. Maybe I can just try a little harder or adjust a little more or do a little.
Exactly.
And it wasn't until I realized that I can say like this therapy has failed
Sometimes
that we
do
can just
everything
move
right.
on.
Yeah.
Yeah.
And it's just not going to work.
Yeah. So it does help too, especially if you have multiple responders on your scene, to
Keep
say
everybody.
like patient has failed CPAP therapy, we're moving forward to BiPAP, or we're preparing for RSI or whatever it is.
Yeah, definitely.
Yeah.
When it comes to BiPAP, again, we're going to start generally pretty low, IPAP of 10, EPAP of 5. And then if you're still having hypoxia, you can, step up in the same way that you do with CPAP, 2 at a time.
Right, because your EPAP is the same as your what?
That's the same as your PEEP.
Perfect. So, and in CPAP, there's only one pressure, so that pressure is the PEEP. So in BiPAP, your EPAP is your PEEP.
And then if you're also obviously monitoring just like before with your CPAP, you're monitoring your end tidal. And if their end tidal is still high or it's going up, or they're still working really hard after they've, had this little adjustment period, which I would say is about like 5 minutes tops, really, go on to increase that IPAP then as well. And the wider that IPAP and EPAP is, that it's a reflection of how much support you're giving them.
Yeah. If you take your IPAP and subtract your EPAP from it, that is the number of your ventilatory support.
Thank you.
So some documentation services like require that number. So that's how you get it. Yeah. On
we had to put so much.
yes, we use ESO for our documentation, and it does ask like a ventilatory support number.
If you're wondering what the heck was that, IPAP minus CPAP. So just like before, again, we're going to reassess. Are they becoming more fatigued, more tired? Is their work of breathing worsened, or is it slowing down because they're getting more tired? Is their end tidal, worsening? If you have access to ABGs or VBGs, where are those? Kind of decide, do I, again, need to move to a more extreme therapy option, but to swallow that all together. IPAP, it's going to assist your ventilation. EPAP, it's going to assist your oxygenation, but both require you to keep checking the human attached to the mask.
Yes.
Check on your patient. There's lots of numbers and data and assessment of like numerical values in ventilatory management, whether you have a vent or not. So just don't get too distracted by any of that.
Right. Have you ever been sitting in the captain's chair and you look up at the monitor and your patient's vitals are fine, except for that you realize that they have now passed out? Ever happened to you? It's happened to me. I'm like, oh, that looks great. And then I can see the reflection in the rear windows and they're unconscious.
You're like, hold on a
Like,
dang
ma'am?
minute.
That's when you say your patient's name, their actual name, not ma'am. You say,
Yeah.
Rebecca?
Right. And then
Rebecca?
they don't respond and you're like,
That's how you know
Rebecca.
if shit's hitting the fan in the back of the ambulance, if I'm calling the patient by their first name.
mm-hmm. You just hear me
Shit's getting
repeating
real.
something a lot in a row.
Tina, ma'am, hello?
Wakey, wakey.
Get up, wake up.
Tina.
Those are all fictional names, by the way, guys. We're just being silly.
Silly little gooses.
All right, so this was a pretty dense episode. I
Yeah.
hope that it didn't put you to sleep. And if you are still awake right now, let's do some recap and then maybe some trivia.
Oh, I love a trivia.
Let's wrap this up in a nice little bow. So just remember, CPAP It's going to be your single pressure. You're only giving one pressure, and it is mainly to increase oxygenation to your patient. BiPAP is going to be 2 pressures, and it is to increase oxygenation, yes, but also provide ventilation for that patient. So, when approaching these patients, make sure you're asking these questions. Is it an oxygenation or a ventilation issue? Can they protect their own airway? And is their blood pressure okay for positive pressure? Are they hemodynamically stable enough to be able, will they be able to endure this therapy?
Wonderful.
And that is all. And now,
I have some.
Are you ready for lightning round trivia?
Did you pull some up?
No.
Okay. I
Quick,
did.
your patient's end title 77. What do you do?
oh my God, scream!
Call the hospital and they're
You-
gonna be like,
Jump on them.
What does
Jump
that
on their
mean?
chest.
Wrong.
Air trapping. Push
Wrong.
them like the little babies.
No.
Push
"Cry,
on their
run
belly.
away.
Absolutely not.
Call 911.
What are we talking about right now?
Needle decompress.
No. Incorrect. False.
I want to give them some BiPAP.
Thank you. Finally.
Do you guys know when CPAP was first used in EMS? This kind of surprised me.
I bet
don't know-
Freedom House used it.
No.
Oh, I bet they did. And
No.
I bet we've been using it for a while, but was it just like a straw that you'd breathe through into another patient or something?
It's probably a reusable mask, right? Remember those? We had
Oh,
those here.
yeah, we did.
So actually, it started in the early 1990s.
Oh.
Oh.
Fun fact: the helmet CPAP was used in Europe during COVID. It was basically a giant clear bubble for non-invasive ventilation. So, yeah,
Like an astronaut mask?
basically an iron lung for your head.
An
Dang.
iron lung for your head.
I mean, that's pretty cool, though.
That's crazy.
Man,
I didn't
COVID,
know about that.
in COVID, they really were just being like, well, let's put you in a bubble tube and see what happens.
Well,
Like, it was wild.
It-
Remember when they straight up were like, no nebulizers for anyone, let them die instead?
Guys, I just
did do
watched
that.
a TikTok video of these 2 girls who are nurses and they like read comment sections on this person. She was telling her own story and she said during COVID she had a patient,
I think I heard about that. I watched this too.
crazy. She called someone, like a doctor. Someone picked up. Someone came that she had not been familiar with. They said, who needs a chest tube? The provider, quote unquote provider, came in the room and said, which chest tube do you want me to use? That's a red flag, she said. I said, oh, I agree. And then she did the chest tube. And the person immediately coded, and blood just came pouring out of their chest tube. Do you know why?
It was in their heart.
It was through their heart, under their subclavian. And then the person said, I shouldn't have done that, and left. And they were last seen getting into an Uber, leaving the hospital, and nobody knows who it was.
That's the craziest part, is that they don't even know who it was.
They still don't know?
No.
Well, at least she didn't. She was like, I got no follow-up, so I don't even know what ended up coming
See,
of
that is
this.
crazy, too, because, like, in the hospital setting, you don't show credentials. Like, a doctor doesn't come in
Especially
and
she
you're
was
like, prove
everybody's
it.
gowned, right? So
Mhm.
Yeah.
everybody's badges were just underneath.
Mm-hmm. Yeah, you're not like, prove it.
It's terrifying.
You can just, like, wander around and be like,
Mhm.
I'm a doctor.
Yeah.
That is
So,
crazy behavior.
What we're saying is, don't wander around in hospitals and stab people through the heart.
Yeah,
That
please
is
don't.
exactly what we're saying. If we could surmise this episode in one sentence, it is that. Has nothing to do with anything I talked about.
We hope that you enjoyed our chaos. There was
Yeah.
crazy stuff that happened in this house during this episode. I will not elaborate.
You
If
don't
you
get
want
to
to
know?
elaborate,
Mm-mm.
we will talk about it on a TikTok.
Yeah. Yeah,
but-
scram.
She
doesn't wanna talk to you.
Yeah, scram.
This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.